Despite significant improvements over recent decades, cardiovascular disease remains the leading cause of death worldwide, including both developed and developing countries. According to the Vietnam Ministry of Health, every year around 200,000 people die from cardiovascular disease, accounting for 33% of deaths. Cardiovascular diseases, including coronary artery disease (CAD), start very early and progress silently over many years. In fact, the disease incidence in young and middle-aged individuals is higher than we often realize. To assess the risk of disease, doctors have become accustomed to using risk factors. These include non-modifiable risk factors and modifiable risk factors. Parameters such as diet, exercise, and smoking history often rely on a patient's self-reported medical history. Meanwhile, LDL, HDL, triglyceride levels are typically influenced by external factors like medication use. Assessing these at just one point in time can make it challenging to fully reflect the patient's condition. Age, sex, or hypertensive status alone are insufficient to detect groups at risk of developing diseases early on. For example, a young person with normal weight, blood pressure, cholesterol levels, who does not smoke or drink, would be categorized into a low-risk group based on traditional risk factors. However, among these seemingly healthy individuals, some could suddenly encounter life-threatening cardiovascular events. How do we mitigate this oversight in clinical practice? Thanks to the advent of genome sequencing technology in the last 2 decades, scientists have identified genetic variants linked to coronary artery disease. Some work through known pathways like lipid metabolism, inflammation, and blood pressure, while others impact vascular remodeling, no signaling and cell differentiation, and millions of other variants with unknown modes of action. So, what are these variants? How common are they? All humans have near identical DNA sequences across the estimated 6 billion letter code for their genome. However, slight differences, known as genetic variants, make each person unique. These variants can be minor changes in a single letter in the DNA sequence, called SNPs, or large enough to alter the DNA structure. Each SNP contributes only a small part to the risk, but when added together, these small changes can create a significant impact. Common hereditary diseases like cystic fibrosis or familial hypercholesterolemia are usually caused by a variant of a single gene, monogenic. Yet they occur less frequently compared to complex diseases influenced by multiple genes, polygenic. Coronary artery disease is a complex multi-mechanism disease impacted by numerous genetic variants. Combined with other risk factors, these determine an individual's risk of developing CAD. So, how do we determine the risk of disease due to polygenic variants? By comparing the genetic codes of people with a disease to people without a disease. If a genetic variant occurs more frequently in the disease group, it's associated with increased risk. If a variant occurs more often in people without a disease, it's linked to reduced risk. The Polygenic Risk Score, or PRS, is computed by aggregating the effects and interactions of millions of variants into a single figure. This score is subsequently standardized to classify individuals into low, medium, or high-risk groups. So how do we assess the accuracy of PRS in CAD? The area under the curve, AUC, is used as a measure, indicating the probability of a model will correctly classify a participant as having or not having a disease. A higher AUC, close to 1, as shown in the left diagram, indicates a higher ability to differentiate disease-affected individuals, as shown in the right diagram. The Polygenic Risk Score of coronary artery disease, or CAD-PRS, for Asians achieved an AUC of 0.8045, demonstrating its high accuracy. So, what are the advantages and applications of PRS? First, our genes are fixed at birth and remain unaltered, making PRS stable and immutable. Second, since everyone's genome is unique, PRS is individually specific. Lastly, PRS is not influenced by other risk factors and therefore has independence properties. In clinical practice, CAD-PRS should be considered as the first risk factor for coronary disease. Used alongside traditional risk assessment, it can greatly improve accuracy and provide early warning. The role of CAD-PRS will vary depending on the individual. From birth, the CAD-PRS can be used to early stratify risk for asymptomatic individuals. When symptoms are present, the CAD-PRS plays a role in screening for causes, aiding diagnosis and treatment. Finally, when a patient has had their first cardiovascular event, The CAD PRS serves to predict the patient's prognosis and secondary prevention. Health Precision Service. We empower science.